Good afternoon and welcome to the Great Healthcare Debate. This event is sponsored by the John Templeton Foundation, the Black Law Students Association, the Federalist Society, and the Health Law Society decided that it was finally time to get together and talk about this historic issue. Our moderator for this event is Professor Yvonne Cripps.
Hello, I'm delighted to welcome our distinguished speakers and all of you who've made it out through the snow and ice. First of all, let me introduce Professor Neville Cox, who is a distinguishing visitor to the law school from Trinity College School of Law in Dublin, Ireland. Professor Cox is also a practicing barrister in Ireland before the King's Inns in Dublin. He specializes in health law and tort law, and he's also a very distinguished author of books and articles on those subjects. Our second speaker, Professor David Fiddler, will be well known to most in this room. He's the James L. Calamaris Professor of Law here at IU and Director of IU's Center for American and Global Security, on American and Global Security. He has also published very widely books and articles which have drawn him to the attention of numerous public bodies. For example, he consults for the World Health Organization, the World Bank, and the US Centers for Disease Control and Prevention, to name but a few. Finally, I'd like to welcome Doug Bandow, a senior fellow of the Cato Institute, who has very kindly made his way through various airports and a lot of snow to be with us today. Thank you very much for coming to see us, Doug. So that's our distinguished panel, and if I might start with Professor Cox, asking him to speak.
Well, thank you very much indeed. I have both a situation of disadvantage and a situation of advantage as I talk to you. The disadvantage is that I have 10 minutes to discuss something which is both amorphous and also illusory, in the sense that we don't really know what the content of reform is going to be. I have an advantage that I am patently a foreigner and therefore can be looked on with sympathy. And also, I could be the person who gives the perspective of the outsider looking in, and that's kind of what I want to do in respect of the issue of healthcare reform. Because in Ireland, where I come from, in the United States, where I am now, the same problems and the same questions perennially arise in terms of what in terms of what healthcare should be about and in terms of what should be provided. In Ireland over the last decade, during the only period in Irish history where there's been anything like good economic times, vast amount of money have been pumped into a health system which has notably got worse. In America, the statistics, and the statistics can of course be used to prove most things, the statistics are equally alarming. Up to 45 or 50 million people who are uninsured, up to 25 million who are underinsured, premiums rising at 4 times the rates of salary, half of all personal bankruptcies attributable to difficulties in finance caused by healthcare, and up to 45,000 deaths annually caused by people being unable to afford healthcare. Now, it seems to me that the major problem, apart from whatever horror might underpin these statistics, is the fact that money is being pumped into the healthcare system. That the United States is pumping twice as much as the average OECD level into healthcare, and yet continually features towards the bottom of most OECD surveys on what constitutes a good healthcare system. Ireland, similarly, vast amounts of money being pumped in, yet hospital waiting rooms with elderly patients suffering from pneumonia on trolleys, unable to find beds. And I think that it is necessary that in both these systems there should be a major and systemic and indeed ideological reform of how we go about providing healthcare. I have to say also that politically or ideologically, I do find myself in agreement with what President Obama said when he first announced his proposed reforms, and quoting from Senator Kennedy, saying that the nation's character must be reflected by the way it treats its most vulnerable. One of the major indictments of the Irish handling of the wealth which it no longer possesses is the fact that whereas interest groups were cared for, the poor, the vulnerable, the sick, the elderly, and the indigents found themselves in a position where their situation got radically worse. Now, so far that's easy. I think it's fairly common case that there should be reform of a wasteful healthcare system, and that the reform should operate at a systemic or root and branch level. Obviously, the more difficult question is, number one, how is this reform to be effected? What is the nature of such reform? And number two, the question which I'm not going to address because I'm not a professor of economics, how do you fund it? But what I want to do briefly is just say what I would think should be the appropriate focus of reform if I were the king of this country and if I lived in a dream world where I could make things happen simply by waving a magic wand. First of all, the current focus of reform, the focus on insurance. It seems to me that this is an obvious center of reform, but shouldn't be the be-all and end-all. The fact is that health insurance is prohibitively expensive for many within American society. The fact is that that has a knock-on effect, not just for the individuals who can't afford health care and health insurance, but for other people too. The fact is that individuals are paying up to $1,000 annually to cover the costs of those who can't afford insurance, apart from any other taxes. So it seems to me quite obvious that there is an economic imperative to reform insurance. Now, how does this happen? I agree with my friend, Professor Tim Jost from Washington and Lee University, that the so-called public option of the state providing a vehicle by which low-cost insurance could be purchased is important. The Irish experience, indeed, has been that this has made the insurance market so competitive, the government cheap alternative, that private insurance companies have had to reduce premiums to the point where they are, in fact, making it difficult for the government to compete. I think it is important that there be some measure of insurance reform. But I don't think it is either the most important way of doing things, most important focus for action, and certainly not the only focus. Because secondly, I think a major focus has got to be on reducing costs per se, not simply on requiring an alternative company, an insurance company, to pay for the costs, but to focus on how we actually reduce hospital costs. How do we avoid unnecessary treatments? And ideologically, this requires us to ask the question, what is healthcare about? What is health treatment for? I'm reminded of the Monty Python sketch in the hospital where the consultant says, make sure you bring in the expensive machine that says ping, because the administrators like that. There is a viewpoint that the most expensive treatment must necessarily be the best treatment, and that treatment must necessarily be better than not treatment. And I think there does need to be a fundamental reevaluation of what we, as a populace think is important in terms of good healthcare? Do we necessarily, for instance, require a situation where there be expensive medicines, expensive drugs, expensive machines used in all cases? Do we listen too readily to what healthcare providers tell us is necessary? How can we make this a more competitive market? Should we require, for example, greater transparency in terms of healthcare providers' costs? Should we require a situation where there is accreditation of hospitals, private accreditation, having regard to the cost of the services they provide? So I think there needs to be a fundamental reevaluation about the nature of healthcare and about the costs of healthcare. And this will involve difficult and dangerous questions about, for example, end-of-life treatment. Secondly, I think, and this has worked in certain countries, I think there needs to be a fundamental requirement, a fundamental imperative for the state actively to promote healthy lifestyles. Actively, for example, to provide cheaper access for low-income families to nutritious and healthy food. Actively to encourage lifestyle choices which will reduce the likelihood and incidence of people relying on the healthcare system. And finally, I think ideologically there needs to be a greater focus on the question of the relationship between the individual and the public need in having a good healthcare system. In other words, a fundamental reevaluation of whether the individual can legitimately say, it's about me, it's about my decision whether or not to have insurance, it's about my demands on the state. People will presumably say this sounds socialist, and it probably does. But I think that this is an issue which concerns everyone and is of such paramount importance that ultimately it may be that the most fundamental and most appropriate reform is simply to say to people, we all have a vital interest in this, we all must play into it. Thank you.
The vast majority of my work in this area concerns international law and global health, so I have to preface what I'm about to say in the next few minutes with the caveat that I'm not really an expert on U.S. healthcare reform. If Professor Cox is the outsider looking in, I'm the insider who usually looks outside, who's now forced to look back inside in connection with this particular issue. What I want to try to do is three things. First, I want to give you a little bit of a global perspective on the U.S. healthcare debate. You've had a little of that from Professor Cox, but I want to share with you some of the things that I run into repeatedly. Then second, I want to look at some important aspects of the U.S. healthcare reform debate, and then I just want to make some final observations about some political realities that healthcare reform, I think, is going to be facing now and in the near future. Now, it probably will come as no surprise to you that U.S. healthcare system is not held in high regard around the world. The circles that I run in terms of global health, there is this pervasive sense of disbelief that the United States remains the only highly developed industrialized country that doesn't have a system that at least strives for universal access to healthcare. I guess I wish I had $1 or €1 for every time I'd heard that sense of disbelief. But at the same time, all right, and you've already, it's good because I think you've already heard a sense of this. The individuals I work with on global health issues are very aware that if in most, if not all of the other national systems from which they come that are striving or that have achieved, in their opinion, universal access, have some very, very serious problems that sound very familiar to those following the U.S. healthcare debates. And let me just throw out a few of those problems. Costs are continually escalating, which is causing all kinds of budgetary and fiscal problems. Rationing of healthcare is pervasive, which is leading to medically as well as politically difficult waiting times for treatment. You heard the example from Ireland. Frustrated citizens want significant change to the overall healthcare system, but please don't touch their individual healthcare situation. All right, and experiments in bringing in more competition have had some impact, but the impact has been more limited than expected, and there is this sense that the status quo simply cannot continue. So all of those things sound very familiar from a U.S. Healthcare perspective. And one vignette, one experience I had sort of brought all of this to light, which was at a WHO meeting that I went to. The evening's entertainment was to watch the movie Michael Moore's Sicko, which many of you may have seen. Of course, I'm the only American in the audience at this particular meeting, and of course you can tell I'm catching it in the neck with regards to this, but to the credit of my colleagues from other countries, they roundly criticized that movie for having such a simplistic view of these other healthcare systems. And the irony of the fact that Michael Moore took 9/11 responders to Cuba for medical treatment wasn't lost on them, because there is a country in which such a movie could never be made. So there is a realization, even with something like that is so globally famous as that movie, amongst the experts, that that doesn't tell the whole story, and these other systems, which are often held up as examples for the United States, are actually suffering from very, very similar problems in connection with what they do. Now, if we turn to the U.S. healthcare debate for a moment, what's one thing that's interesting for me to sort of looking at this from my perspective is that, you know, both sides of the debate, and again I'm going to simplify things here, but you get remarkably similar diagnosis and prognosis from sort of the right and left in terms of the problems that we face here. So let me just throw out some areas of agreement between the sides on the healthcare debate in the United States. First, we are facing a crisis that absolutely must be addressed. I think there's agreement on both sides in terms of that. Second, costs are growing too fast in both the private sector as well as the public sector, and those have to be brought under control. Third, choice is too limited for too many people, so choice must be increased in the system. Fourth, coverage of the population is not acceptable. We have millions of people that don't have health insurance or inadequate insurance, so we need to have greater health insurance coverage for the population. I think there's agreement on that. Fifth, competition in the system is suboptimal and competition has to be increased. Sixth, the U.S. Constitution, specifically the Commerce Clause, gives the federal government the power to make radical changes. Again, the nature of the radical changes are different, but there seems to be agreement that the federal government has the authority to do this. And then finally, radical change of the American healthcare system is consistent with fundamental American values. The two sides aren't necessarily talking about the same values, but they both come at this from the point of view of it is consistent with our ethos in the United States. Where we get the radical difference, obviously, is in the treatment that's prescribed for the patient. So if the diagnosis and the prognosis is similar, the treatment prescribed is very different here. And I'll just throw out a few comments in connection with that. I think you're going to hear more in terms of the free market approach from Doug when he talks, but I think it might be important just to throw out some of the things that we're talking about. And obviously, I went back to sort of President Obama's major reform principles, and some of those were included in some of the legislation that's been adopted. Some were not to the extent that the president liked. But I think given where we are politically, it's a good idea to sort of go back to that and then contrast it with a very different approach, and then to think about how we go forward with these very different perspectives in the current political reality. At least, and many of you are familiar with these ideas from President Obama. We basically leave the employer-based insurance system alone. That covers about 75% of Americans. So you've heard the president say, if you like what you've got now, nothing's going to change going forward. There needs to be an individual mandate for everybody to have health insurance. So if you haven't purchased some, you're going to get penalized for not doing so. The creation of these health insurance exchanges, which will increase the opportunity for people to buy health insurance. Subsidies to the poor are increasing Medicaid coverage for the poor to provide them with health insurance. Money for the plan is going to come from savings squeezed out of reducing wastes and inefficiencies in Medicare and Medicaid, as well as new taxes, for example, new taxes on so-called Cadillac health insurance plans. And all of this, we're told by the president and the Democratic Party, is not going to add a dime to the federal deficit. So we can get radical, systematic change without increasing the deficit at all. From the other point of view, the treatment prescribed here is really to move much more vigorously in a direction that would help a free market function better in the healthcare, insurance and healthcare services sector. The argument is we don't really have a functioning market here, and the idea is to move much more aggressively in that direction. You would get the benefits that we're looking for in terms of those problems achieved if you can actually, really move vigorously and systematically in that direction. So that would require developing really national markets for health insurance by engaging in deregulation of the way in which health insurance markets are now controlled, or in some respects monopolized from a governance point of view, or using vouchers, for example, in the Medicare area to free up senior citizens to be able to purchase more efficiently and effectively with regards to that. Again, utilizing the power of the market and consumer choice to produce the efficiencies and bringing the costs down and coverage up with regards to that. Empowering individuals more through greater or more aggressive use of health savings accounts so that you control your medical and healthcare dollars and spend them as you will, as opposed to having the government tell you how they have to be spent. And then also reform how the federal government or allocates funds for Medicaid to produce more efficiencies in the system and actually to deliver more money to those that are in most need of those types of resources. And again, I think you'll hear more about that approach. But there are these ideas which are highly developed in some of the literature that at least I've looked at as an alternative to the way in which President Obama and the Democratic Party have approached this. Now, of course, we're now in the situation where we sort of have to take a political reality check with regards to all of these particular issues. I'll just make a couple of comments on each of sort of the perspectives on this before wrapping things up. At least from the point of view of what I'm able to pick up in discussions on this issue, there just is really, I think, a fundamental disbelief, at least in terms of the President's and the Democratic Party's approach, that this plan is going to is first of all going to significantly increase the role of the federal government in health care, and it's not going to add a dime to the deficit. I think people don't believe this at all, or that it's not going to have a significant impact on the employer-based system. So this idea that you have insurance with your employer, and if you're happy, that's fine, nothing's going to change. Again, people simply don't believe that. If this is systematic reform, it's going to affect everybody. And if you're going to significantly increase the role of the federal government and you're telling us that the deficit is not going to increase a dime, I think people just simply do not believe that story. In terms of the more free market approach to this, I think this tends to make people also very, very nervous because in some respects it's a much more radical and much more systematic reform of the healthcare system than what is being offered from the Democrats or from the President. And it really would affect everyone. And I think it would affect everyone, including those voters who actually, again, like what they've got at the moment and aren't radical changes for somebody else. So if you're really proposing a radical change that would alter fundamentally the entire system, that I think makes people nervous as well. Not necessarily a disbelief about the potential benefits, but just the nervousness about making such a radical change to the system. So I think we've got a real problem politically speaking from, on both sides of this. My final point really is then just to think about where we are in terms of the politics of this now, and nobody in this room needs, educating in terms of the political difficulties with the healthcare reform is in at the moment in Washington, D.C. And unfortunately, I think we're in for a short-term and near-term period where there's going to be no progress on systematic healthcare reform because of the political fights that are going to happen leading up to the midterm elections in 2010 and then leading into the presidential elections in 2012. So I think we're in for a period of short-term sound bites and political platitudes as opposed to real systematic healthcare reform, which I think is, obviously unfortunate in regards to that. I'm going to stop now. I had some other comments to bring it back to the global level in terms of the fear that my colleagues and other people in other countries have if the United States doesn't engage in systematic healthcare reform. And it doesn't have to do with Michael Moore. It has to do with the declining influence, power, and prestige of the United States. They're not happy with U.S. healthcare system, but I can tell you this, they would be much more unhappy if the United States, because of the deficits, because of the fiscal problem that we're having with healthcare, if we don't fix this, as we enter a multipolar world, the United States' influence around the world is going to decrease, and that makes them much more nervous than the problems that we have with the U.S. healthcare system.
Well, it's a pleasure to be here. I never expected I'd have to come to Indiana to have less snow on the ground than in my front yard. I have about 3 feet worth of snow currently piled up in Virginia. What we're talking about clearly is a critically important issue, and it is being shaped by politics. The announcement made yesterday by Evan Bayh just shows how the environment has changed. Part of his analysis, I assume, is what he said. He doesn't like the environment in which he's operating. Another part could be he was in for a rough campaign. This is a man who last year was thought to be a shoo-in for re-election, and suddenly people are talking about serious opponents, and polls are showing him behind, even Republican congressmen. That shows the environment that we're in that is going to shape what happens the rest of the year. Nevertheless, this remains a very important issue. I mean, healthcare is important for a couple of reasons. One of which is it's a huge chunk of the U.S. economy, roughly 17–18% of GDP. It also has a special feel to it. I mean, we tend to talk about it as a right. You know, it impacts us very powerfully as individuals. Anyone who has an elder parent understands how difficult these choices are, especially when you get to end-of-life treatment. You start talking about treatment alternatives. You know, these things are painful, and I can speak from personal experience on that. So the question is, what do we do about it? I think it's important to recognize it's very heavily a prudential issue. I don't like arguments about rights because, well, what is it a right to? Do I have a right to cardiac operations? How many? Do I have a right to artificial knees and hips? What do I have a right to? I mean, there's a full range of treatment out there. I mean, we have healthcare, which is this, it goes from purely voluntary, such as we typically view cosmetic surgery, to what we view catastrophic. You're in a car accident, you need something. It's a very complex creature. But I think what we want is a system that tries to make the right trade-offs. And I think whatever the system is, there is no perfect system. However private, however public, the trade-offs are inevitable. If you want high coverage, if you want everyone covered, it's going to be expensive. There ain't no way around it. The notion in Washington that you can kind of give more people benefits to more services and cut the costs, it's a fantasy. It's politicians going to go sprinkling pixie dust and repeal the laws of economics. If more people want more services, you've got to spend more. So you've got to make some fundamental decisions in terms of how much do you spend, who gets what. And to my mind, the real issue here is who makes those decisions. Do we want to centralize those decisions politically, or do we want to try to decentralize those more and depoliticize them? Our current system in many ways is the worst of both worlds. It's a hybrid. It's not public and it's not private. Government provides about half of all spending, and the private system is shaped particularly by the tax code, which has, it's a long history. It goes back to World War II. It's completely inadvertent, but we have an employer-based insurance system. It makes no sense. Why would you want to tie your health coverage to your job? So that if you lose your job, the very moment you're economically most vulnerable, you lose your health insurance. It's an utterly insane system. But it's a system that arose through basically wage controls in World War II. The tax system says employers can provide health insurance and they write it off. If you buy it, you have to use after-tax dollars. So we all say, please let the employer buy it. And what it's done is it's moved us toward a system that is more comprehensive as opposed to catastrophic. We now view insurance should cover everything. Insurance should cover Viagra. That's maybe perfectly reasonable to use Viagra, but this is a decision that we're making. This is prepayment of expected medical expenses, it's not insurance. And what we've got between this very expansive private insurance as well as government programs is a very heavily third-party payment system. Roughly 90% of all costs are paid the first instance by somebody else. Now, we all ultimately pay for it, whether it be through premiums or taxes, but at the margin where decisions are made, somebody else is paying. Now, healthcare, again, is not purely economic good. You're being wheeled into the emergency room after the accident. You're probably not going to call out for bids for anesthesiologists. But there are a lot of places where, in fact, you can make choices, where you buy your prescriptions. How much do you spend? How often do you go to your GP? A lot of these things are decisions that are affected, especially where providers know that you won't be paying for the treatment. So the question of, you want something, they want to provide it, it seems like win-win. Well, imagine if you walked into an automobile dealership and you had the same deal. You could pick it, you pointed a car and somebody else would write a check for 90%. Would you buy a different car? I can tell you I wouldn't be driving a Geo Prism if that was the system. I'd go and get myself a Porsche. So I'd say that's a pretty good deal. Let somebody else pay 90%. Well, that's our healthcare system. It says give the cost to somebody else. So it affects incentives very, very powerfully. And that matters. And what we see is a system that's also employer-provided, has enormous perversity within it. The employer provision of health insurance, number one, you lose your job, you lose your insurance. You lack portability. You change jobs, suddenly you worry about health insurance. And it tends to be almost as lacking in choice as the government system. Your employer gives you a plan. Now nobody goes out there, you don't go to your employer and say, please give me automobile insurance, please give me homeowners insurance. You choose. And you choose level of coverage, you can adjust benefits, you can make all sorts of decisions. Do you have a lot of household goods? You raise that. Do you, old car, you don't have comprehensive. I get one plan from my employer. I'm rather happy with it, but I don't have any choice in that. This is part of the employer provision. So there are a lot of things that go within that in our current system that really make no sense. It's a pure accident of history. It's not an intelligent way to run your healthcare system. Now, there are strengths of the American system, which is if you get sick and are covered, this is a place to be treated. You do a lot better if you have cancer here than you do in Europe. Just the reality. And now, we don't do as well in overall health indicators, but a lot of that's because in many ways we're very stupid people. If you go and you look at life expectancy, for example, we fall near the bottom of the OECD countries, the industrialized countries. Strip out homicides and accidents, and we're in the middle. Americans have a real problem of eating too much, and I can speak to that. Now, this matters. This has an impact on health outcomes that is utterly disconnected from, kind of the system that we have. So our challenge then is, how do we preserve strengths of our system and deal with the problems out there? And I think there are two essential problems, both of which have been mentioned. One of which is cost. We spend more than any other society. Now, I want to emphasize the problem is not that we spend X amount. The problem is we don't spend it well. I have no idea what the correct amount of our spending in our society is on automobiles. Is it 5% of GDP or 20%? I don't know. What's the correct amount that we should spend as a society on beer? I don't have the slightest idea. So for the same reason, I don't have the slightest idea what we should spend on healthcare. A wealthy society with an aging population and new technologies, it probably makes sense to spend a fair amount of money. I have a $60,000 knee. Now, I don't look it, but I used to be a marathon runner. Now, that has an impact on knees. I got a knee replacement 5 years ago. Now, I could spend $60,000 on a new knee, or I could spend $60,000 on a luxury automobile. Which is the better way to spend it? I'd say, hey, I'll take the new knee. For my set of values, this is a good trade-off. The problem is we have a system that's very inefficient in terms of how we spend. So what we do is we don't get the results we should get. We spend twice as much as the OECD average, and we don't have twice as good medical treatment. So that strikes me. The issue is not we spend too much, we spend more than we should for what we get. We spend inefficiently. The second issue is the lack of health insurance coverage. It's a very complex number. The lack of health insurance doesn't mean you don't have health care. It means you don't have as good a health care. People are more likely to show up at emergency rooms. They don't have primary care physicians. They're not getting continuity of treatment. All of these things are bad things. But that number of 46 million is a very complicated number. It includes illegal aliens. And it strikes me the question of what you do about undocumented workers really is an immigration problem. It's not a healthcare problem. It's a very complex issue. One can do a debate entirely on that. But about 10 million of the 46 million are people who are here illegally. We have to decide what to do about that, but that really is kind of a separate issue. About 10 million of the 46 are people who, in fact, are on federal programs and answered the question wrong or are eligible for it. And about 10 million are people who have, have 3 times the poverty wage income. There's still too many people, but it strikes me if you look at that number, you recognize radical change, I think, is less necessary if you're talking 16 as opposed to 46 million. The challenge is any of the systems out there, and we're talking about the international, the foreign systems, or the proposals on Capitol Hill, you can't get away from these trade-offs. And as indicated earlier, all of the countries with nationalized systems have trouble in terms of cost. The OECD countries actually have had medical expenses rising faster over the last decade than in America. They started at a lower base, but they're all faced this trouble. And you read the newspapers, whether it be Ireland, or Britain, or Canada, the debate over how much we spend and who has access to what, these are bitter, bitter, tough debates. We can't get around that. The legislation currently proposed on Capitol Hill, it's the same thing. I mean, all of these are very complex. The moment you have a mandate, suddenly you have to have everything else. If you have a mandate, you have to decide what a policy is that satisfies the mandate. If you're going to mandate it for poor people, you have to have subsidies. You know, once you step in, all of these controls expand. And if you're going to expand coverage to more people, you will spend more. So you either have to be prepared to spend more or you're going to have to cut access to care. Now, there's a hope in there we're going to adjust Medicare benefits and do this, we're going to have panels. But you have to realize these are very painful. The recent debate over mammograms. An expert panel said, you know, the old recommendation, women should have a mammogram every year. We don't think so. It created a firestorm. Now, I don't purport to be a medical expert. I have no idea. But that just shows, do you want a national standard where somebody in Washington says, well, we need to save a little money, you know. Shouldn't have as many mammograms. Well, my guess is if you're worried about breast cancer, you might decide that, hey, wait, even if this costs more, it's a good investment in my health care. So the question is, do you want to have these kind of decisions made in the national system? So what I would throw out is the basic challenge for us is who makes these decisions? Do we want to have these nationalized and kind of politicized, where all of these extraordinarily tough trade-offs become political questions, or do we want a system that's much more decentralized? And there are a lot of parts of that. Part of that, I think, is changing the tax system, having health insurance bought by individuals as opposed to companies. It's expanded pooling options, so it's not just companies, it's other things. Looking at alternative delivery systems and licensing, can we reduce the cost? And it's being willing to pay the cost to care for people who need coverage. Medicare and Medicaid are underfunded. People don't get the care they should. Doctors don't want to take those. We have assigned risk pools in the state level. Those things don't get the money they need either. We make promises and we don't cover them. That's where we need to invest the money, and it's going to be expensive. And as a good society, we're going to have to put money there. But more broadly, I'd like to see us move in a more decentralized, patient-oriented system as opposed to nationalizing these issues and making them all political decisions. Thank you.
Well, thank you very much, all our distinguished speakers, for an excellent contribution to this very difficult debate. I was surprised in some ways by listening to all three speakers and concluding that there's a remarkable degree of agreement amongst them, although they obviously come at this different issue from several perspectives. And what we've heard is that this is going to be a painful reform, that reform, first of all, is essential, that it's going to be very painful and difficult. Now, because I know a lot of you have to go to other classes after this, I'm just going to make a couple of very brief and I hope slightly provocative remarks, and then open it up to the floor, because I know a lot of you have strong views on this. But when I heard the speakers just now referring to the pain that will be involved, the difficulty of the issues, I did wonder whether we ought to focus slightly more on the President's attempt to grasp this painful and difficult issue, to actually make these reforms that all three speakers agree are so essential. Just on a sub-point, I was interested by what you said, Doug, about the mammograms, which I think is a very interesting example. And I noted when I was looking at the Hawaiian healthcare system, which in some ways is slightly similar to what's on the table and what will be discussed on the 25th of February, that one of the striking things that jumped out at me from all the Hawaiian statistics and the experience that they've had there with the more centralized system is that Hawaii has the highest breast cancer incidence in the United States, but the lowest death rate. And that is highly suggestive of a very effective screening program because of the wide access, the greater availability of healthcare to all in Hawaii, although of course you can always argue about statistics, but you can't contradict the statistic that having had a centralised system for many years, they have the highest incidence and the lowest death rate for that particular illness. So, coming back to my opening point and opening it up to the floor, I'd like to perhaps get some debate about the President's attempt to deal with the very difficult issues that the panellists have rehearsed. And of course, we'll be seeing much more about that in the media from the 25th of February when that meeting takes place in Washington onwards. So, questions or comments? Yes.
I was wondering, and since you talked about decent, I'm sorry I don't remember your name, the professor to my left, you're right. You talked specifically about decentralization, so perhaps this question would be best directed to you. But I'd be interested to hear from everyone's perspective. Where should we look? Do you see a model, whether at the state level or a foreign level, of something, of a direction where we should be heading? Do you see something that we can look to as a lighthouse in the distance for where we should be directing our reform?
Well, I think we can learn from all systems. I mean, the internet, European systems vary dramatically. The Swiss have an individual mandate. The French have kind of an employment area-oriented insurance system. The British have direct government provision. The Canadians have single payer. I think we can learn certain things that seem to work within those systems, and we can learn certain things that don't particularly work. I don't see any system out there that has everything that I would want. What I would say is that basically nobody else does the employer-based insurance system. That does strike me as a reason to try to move away from that. And I'm afraid that the president's reforms would cement that. I'd much prefer that we see an attempt to try to move us away from that, because I think that is the cause of many of our problems. Lack of portability, lack of choice, part of the third-party payment system, and most other countries try to avoid that.
Let me just add a quick comment on that. I think that's right, and I think that's part of what makes people very nervous about moving away from the system that we have right now. Regardless of, warts and all, people are just very nervous about it because there isn't something that we can sort of say, here's a decentralized system that works and is a model, because you don't see that anywhere. So this alternative approach, which, there's lots of sophisticated writing on it. It's a very different type of approach, I think, is what makes people nervous, because we can't say, hey, look, that it works in that country. I just briefly want to say, in regards to that issue in terms of the employer-based system, I want to throw something out, perhaps even to, be provocative here. I'm not sure the president is actually tackling the difficult issues here. And this is what people are really having a hard time believing. First of all, he says, 75% of the American population, employer-based system, if you like what you've got, nobody's going to touch that. You can't do systematic reform and have that be believable. Second, we're going to increase the role of the federal government in health care. That's absolutely clear from that approach, without increasing the deficit at all. Just simply not believable. So if we're going to believe the president actually wants to tackle these difficult issues, why don't we have some reforms on the table that are systematic, that deal with the issue, the employer-based system, and actually are honest with the American people about what this is going to do to the deficit?
If I may just briefly pick up on David's point there, I think in relation to the fact that there is nervousness because there is no other society which has a decentralized system of the kind that has been proposed. I think the reason for that is because of the recognition that that would leave a large group of society, and indeed in America, an increasing number of the middle class, without any coverage at all, any access to health insurance. And that's, I think, why such a system hasn't evolved anywhere else. But that's a personal opinion, Neville.
I would just say, in terms of what the president is doing, and like most Europeans, I'm a fan, I think he's facing a political challenge, a really difficult political challenge, which is that the reforms which are necessary go well beyond, in my view, insurance reform. If he's going to make genuine systematic and systemic changes, it's going to be enormous, and yet he's been accused of moving too fast. he's been accused by the moderates of trying to rush things through. So I think he's facing that particular difficulty. For what it's worth, I mean, I'm kind of enamored with the British system of state provision of coverage, and I personally think on this issue that the ideal would be for reform at a national rather than a localized level, and I'm completely inconsistent in my principles there, because in most matters I don't like the idea of federalization of issues. This one I just think it's so important, and in terms of efficiencies I think would be done better at a national level, but as I say, I'm very much the outsider looking in on that.
Yes, I see several hands up. First the gentleman in the red sweater at the back.
If we move to a more individual choice system, as you proposed on my left again, I understand that this would create incentives, and if you're paying for it, you have a choice. You can choose which treatments and which options. You might, in fact, choose to live a healthier lifestyle so that you didn't have to face some of the even more difficult questions. But you yourself said that we as Americans don't make very wise choices some of the time, if not much of the time, especially regarding our health. With all those incentives in place, they would be wiped away if at the end we covered their rear end. For example, would we be prepared to, in the emergency room, to say, you chose this plan, you chose this treatment, and now you have this problem that's not covered? Too bad for you, you made that choice.
Well, look, I mean, we run into that problem through a lot of issues. The question is, at what point are we willing to sacrifice individual liberty? You decide to go mountain climbing, and you have a terrible accident. Now, you chose to do it. Now, we could prohibit you from going mountain climbing because you're causing a cost to the American people. Or we can say, you know, we're going to realize that it's kind of costing us some cash, but we're going to cover you. Or we could say, too bad, life is tough. My guess is we won't do the latter because we're humane people. But I think the first would be wrong, to say, sorry, you can't do it. So my reaction is some of these things we're going to have to muddle through. Again, I have no perfect answer here. I think what we want to do is change the incentives for the bulk of people who can deal with those. And at the very least is to know the cost of things. I mean, medical savings account was the first, doctors' offices, a number of them said the first time they ever had somebody ask them what something cost was when medical savings accounts came in. Until then, cost did not matter. Well, you just imagine a system that operates that way. I mean, just imagine. I mean, for doctors and for, I mean, it creates the worst incentive for both sides. I, as a patient, want everything. I believe I have a right to it, give me anything. And I, as a doctor, in part, malpractice concerns, but satisfy the patient, and what the heck, if it helps, possibility of helping them, I'll give you everything because somebody else pays. So I'd say we need to change that. And I think on the issue of can people afford it, look, we're going to have subsidized people who need help. We do that in terms of welfare and housing and food. People who are poor have to be helped. And that's where I say we have to be prepared to pay the cost of that. People who have chronic conditions or uninsurable, things like high-risk pools can help them, but it's going to cost us. And what we do now is we promise benefits and don't want to pay. We tell the elderly we have this great system. Last year, the New York Times did a story about how doctors increasingly don't want to take Medicare because the payments are down. The same thing with Medicaid. We say, poor people, we're going to cover everything, but by the way, we're not going to pay doctors enough to cover you, so they're not going to want to take care of you. Look, we have to bite the bullet on that. We're going to have to spend money on those.
Just briefly in response to the questioner's point up there, in 1967, the country in which I was born and raised, New Zealand, abolished personal injury tort litigation. And part of a major philosophy behind that action was that you'd look at society more as a whole and you'd focus on prevention, healthy eating, more exercise. And to a large extent, that abolition of personal injury tort and its replacement with something akin to a workers' compensation scheme has worked. Accident rates have fallen. People have lived healthier lifestyles. So there's a considerable degree of public intervention there and replacement of private sector tort, which, taking a broad view, has been quite successful for New Zealand, which incidentally also operates a well-liked public healthcare system along the lines of the English one. Yes, gentleman up the back there.
A market
any kind of market system can lead to the efficiencies in either of those realms.
Well, I think the broader question is, can any system be efficient? Look, Medicare has a $90 trillion unfunded liability. You all are going to be paying for my Medicare, and I thank you very much. It is not an efficient system. On administrative side, it looks efficient primarily because the average payment in Medicare is twice that of normal health insurance plans because the elderly consume more health care. We give the elderly a plan that, many of them go out and buy Medigap insurance because they don't actually like the coverage. It only covers 80% of certain things. So it's not as if, is any system going to be efficient? The problem of international systems, they have the same kinds of problems. They make choices on access to care. Britain has the NICE, the National Institute for Clinical and Health Excellence. It makes decisions in terms of whether it thinks treatments are cost effective. And these are brutal judgments. It decides whether or not the life extension of a particular treatment is worth the cost. 2 years ago, a woman had breast cancer. She wanted a new pharmaceutical that was quite expensive. NICE, as it's called, decided that that was not worth it. And again, these are tough decisions. Where do you put your money? You have limited resources, unlimited wants. It said, sorry, we don't think the benefits are worth it. She said, well, I'll tell you what, I'll buy it myself. And the agency said, no, that's not allowed. If you top off, as they put it, that violates the equality desire that we have, so you lose all of your NHS benefits. You'd have to pay for everything, which of course would have ruined her. It created a political firestorm, and they reversed that. And she got, that she was allowed to top off, as they say. Well, what's efficient?
But so were a whole class of women affected in the same way. In other words, the political response forced them to
That's right, exactly. But I'm saying that it had nothing to do with efficiency. They tried to make an efficient ruling according to their criteria in terms of cost and benefit, and they lost politically. The Oregon, through Medicaid, has tried to come up with a system. It basically rank orders. It says we have a limited budget for Medicaid. We'll cover certain things, and we're going to cover the most important stuff. The Office of Technology Assessment, a former federal agency, analyzed what Oregon had done, and it said, despite this attempt to scientifically order kind of treatments, powerful constituency groups came in and complained, and the agency officials had to move by hand treatments to satisfy constituency groups. There's no efficiency there. These are all extraordinarily emotionally and politically charged decisions. So I'd say, yeah, will a market system be efficient? No, I'd argue it'd be more efficient, and incentives matter. So try to improve the incentives, recognizing we're not going to get perfection under any system, figure out how to cover people who need coverage, figure out how you can get better incentives for the bulk of people.
Yes, the woman in the black sweater and then the gentleman in front of her in the grey sweater.
I'm a little bit concerned about pre-existing conditions because I happen to have one. And you look at the economics of insurance right now, they'll just exclude most pre-existing conditions for 1 year. So I have no point in paying for insurance. But at the same hand, economically, it doesn't make much sense for an insurance company to pay to cover pre-existing conditions if it knows there's a risk that my pre-existing condition could trigger something much beyond the benefits I'm paying in. So under a free market system, how would you realistically cover people with pre-existing conditions if you wanted to go that route?
And that's one of the president's major concerns with his proposals to address that point.
No, there are two parts to that. One of which is the more pooling you have, you can get around that. You go to an employer, they cover you. An employer, that's one of the advantages of employer. Look, I went through this. I lost my job. I had COBRA for 1.5 years. I have a replacement knee. So nobody's going to cover my knee coming in on that. I found a new employer and got coverage primarily because I could get health care coverage, a small part-time thing. But pooling, so can you have expanded pooling in an individualized insurance marketplace? And the second is subsidies. There are a number of ways where the state can come in and help pay for people who either have chronic conditions or are uninsurable essentially entirely. And that's where we have assigned risk pools, for example. You can have risk adjustment. You go back retrospectively in terms of insurance companies, see who they've covered and whether some of them had unusual risks in people they've covered. And again, I think it's going to cost. That's one of those areas where we're going to have to be prepared to spend some money, but I'd focus on people in need. I don't design the entire system around that. I say, how do we expand a system and cover people like that? But I think it's a need that has to be addressed.
Could I say, because exactly that issue arose in Ireland 2 or 3 years ago, that this is to an extent why I favour the notion of a public option within insurance providers, is that the state insurance company is required to take on anybody essentially, irrespective of age or previous condition. The private insurance companies weren't taking on people in this position, so therefore they were able to charge generally much lower premiums. Therefore, the bulk of the people who hadn't got pre-existing conditions, including age, incidentally, went to the private companies who were able to undercut the state company. And the state company, the government was going to pass a law saying that, in fact, for risk equalization reasons, the private insurance companies were going to have to some extent, fund this. And this was deemed to be illegal under European law. So I think, it's a genuinely big problem, but the only way that I can see around it, because I can't get my mind around the notion of an insurance company being anything other than a business, is for some state involvement, either to subsidize premiums or alternatively just to provide a state-run insurance mandate.
Yes, the man in the grey sweater.
My comment and question is for the gentleman in the middle. I'd like to just turn to the politics more of this issue and put back on two specific points you made. The first being you said that nobody believes that the president's plan will be deficit neutral over the long term. And I'd like to point out the CBO indeed says that it will be neutral if not produce a surplus over 10 years. So I don't think that's factually accurate, and I'd like your clarification on that point. And in regards to that, I think you've been quite honest with the fact that there will be increased taxes, and it's not inconceivable that a plan that increased taxes could become deficit neutral. And the second point is that you indicated there are broad areas of agreement, and one of those was that change is needed. And you indicated that, or you suggested that conservatives and Republicans have signed on to that notion. And I'm not seeing many times that in the current political debate that Republicans are willing to even play ball on this issue, and maybe it's because of my political ideology that I'm blind to this, but if you could clarify both those points a little more what you were thinking.
Yeah, no, I mean, everyone is aware that the CBO has come out and said this will be deficit. Politically, I don't think people are buying this. And I think part of that has to do with the fact that when we understand that the government is going to increase its activity in a given area, historically speaking, we do not see government spending going down. And so I think and I think this plays into what happened in Massachusetts. The concern with the federal deficit and the spending that before we even get to health care, right? So people are increasingly skeptical of claims that a massive change on the scale of the health care reform that's being proposed is not going to add a dime to the deficit. We don't care what the CBO says. It's not believable in terms of how we've seen the federal government issue entitlements and continue to fund them at higher levels in the future. Yes, there are proposals for taxes to be part of that, but the majority of the savings, right, we're supposed to squeeze out in Medicare and Medicaid without cutting any of the benefits that are going to be increasing, which aren't even funded, at the moment to begin with. It just doesn't. I think people are starting to, not have confidence in CBO projections with regards to how this is going to affect the deficit. Secondly, if this is the most important issue for purposes of the president and the Democratic Party, why wouldn't they be willing to fund this out on deficit spending? It doesn't make sense. So I think people are skeptical about the argument that this is the most important issue, but we're not going to do deficit spending on this. I don't think that adds up in terms of the political calculation that people are making. In terms of conservatives or Republicans, I think it's a very mixed bag of things. I think many Republicans are just being obstructionist about this. They don't have any ideas. All they want to do is win the midterm elections. There are, however, very sophisticated proposals put out with regards to how to go about this differently, and I laid out some of those ideas that at least I've seen in the literature, which would, I think, part of what makes people nervous about that is that would really be radical reform. We're not taking 75% of the problem and saying, if you like your insurance, nothing's going to change. That can continue, which is what the president is saying, which again, people think that just isn't, we don't believe that as a proposition for what is supposed to be radical reform, because as Doug has pointed out, a major problem with the way that this works is the employer-based system. And the president's saying that's not going to change. If you're happy, that's fine, don't worry about it. It's stretching credulity with regards to how I think voters are looking at those issues. Not necessarily that the Republicans have an answer to the problem either, But that's where, unfortunately, the anti-incumbent feeling is catching the incumbent party in the neck at the moment.
And you have to understand those numbers. I mean, the CBO takes what is given. So the CBO does a 10-year time frame of analysis, and it accepts whatever it has provided as legislation as being realistic. Now, if you look at their numbers on the 10-year projection of the Senate bill, the first 4 years, because all the benefits kick in late, the first 4 years cost $9 billion. The last 6 years cost $839 billion. The legislation is written for the CBO analysis. If you do a 10-year cost analysis as of year 5, it's a $1.8 trillion bill. And if you add in all the stuff that's not associated with expanding coverage, it's a $2.5 trillion bill. And that even assumes that you believe the legislation. Will we cut $500 billion out of Medicare? Well, number one, Medicare has a $90 trillion unfunded liability. It's not a pot of gold that you can spend money from. You cut out $500 billion in spending, now it's only $89.5 trillion in unfunded liabilities. Well, it's progress. It's not money to be spent. And the second is these cuts are not likely to happen. Since 2003, Congress has legislated a 21.5% cut in doctors' reimbursements. Now, in 2003, 2004, 2005, 2006, 2007, and 2008, it put it off. And they had a big argument last fall trying to decide what to do about this. They won't make the cuts. So you're presuming the cuts will occur. The CBO in its analysis, very careful, these are fine economists who have political masters. They said all of these estimates that we make presume that major pieces of legislation will be passed and remain unchanged for 2 or 3 decades, which often is not the case for major pieces of legislation. If you look at Medicare in 1965, the estimate of Medicare spending in 1990 was $12 billion. In 1990, it spent $110 billion. Every government social program and healthcare program has cost more. I mean, that's the reality. So
Wasn't that the point of Obama making a step from Congress to control those costs?
yeah, but the thing is, do you believe that, again, the mammogram recommendation came from an independent panel. Immediately, Congress, both houses voted overturn it. Mandate, we will have annual mammograms. Now, whether or not that's a good idea is a separate issue. They would not do that because of the political cost. So if you believe that, politicians will stand by and allow the growing share of the elderly to have their benefits cut. Please, assume that. But I'm just saying the reality is not that. And that's the problem with the CBO is a very fine organization, but its estimates are very carefully tailored, and the legislation is written specifically for the requirements of CBO analysis because they wanted to be able to say they cut the deficit.
But I think the point you make is a good one in this sense that, again, looking in, the bigger problems facing this legislation, not economic, they're political. It's just a shame that it's got to the point that it is the political football. It's the vehicle wherewith Republicans can do well in the midterms, Democrats can save themselves. So this issue, which is so vital to everyone, because lads, we're all going to get sick, right? So vital to everyone, has become a political football. It became political football in 1993. It's become political football in the decades prior to that. And it will continue to do so precisely because it is so important. And what distresses me looking at it is I think, absolutely, if this is important, then economically it's worth it. And real change could occur. But there are going to be the political forces on both sides, which mean that what will happen will be watered down and won't be genuine.
There's so many people wanting to speak. Sarah Jane first, and the gentleman up the back there, and then Trent.
Well, I had actually, earlier I wanted to ask one question, and more recently I wanted to shift the question. So I'm going to ask the more recent question first because it flows far more purposefully from the remarks that Mr. Cox has just made. It seems to me that there is some likelihood that it is easier to achieve this level of reform in a parliamentary system than the system that we have.
Yes, please.
On the issue of a parliamentary democracy where the executive is drawn from the legislature, yes, I mean, quite clearly it would get done more easily, and certainly in terms of dealing with, for instance, the financial crisis, both England and Ireland, for example, have pushed through very, very unpopular and difficult measures precisely because they can. So to that extent, yes, I think so. I think it would work more easily. I quite like elements of the bipartisanship thing, though, because I think you get different ideas, good ideas, being allowed to play into an overall package rather than simply having one ideological view of how things get done.
I mean, parliamentary systems are essentially elected dictatorships. So, yes, you can get your reform through. The founders of our nation didn't want that, and they created a system where that is simply impossible. I think it argues for incremental reform. The challenge in this case, though, is that I think there really are two different directions. So to say we want Republicans and Democrats, or at least ideologically principled conservatives and liberals, which is different from Republicans and Democrats. If we want people who care about the issue, it's hard to come together because it is a difference of direction. So, to simply say we won't do as much of what we want to do isn't really a positive inducement to the other side. And I think that's the challenge on this issue. It really is, there are a few things one can argue about, but a lot of them, it really is a very different direction where you want to go.
So then my earlier question, if I can still be involved. May I? Yes. My earlier, for a long time I thought that there were a few things that could be tried incrementally that might yield reasonable results and set the stage for more political ability to deal with the issue. And it occurred to me that one of them would be for the federal government or somebody to offer something that was a standalone policy, a lot more like flood insurance. Flood insurance covers substantial liabilities. You can get it mostly from the federal government. Lots of people have it, and it's relatively inexpensive, because not all of us are going to get cancer, and not all of us are going to have catastrophic accidents of one form or another. There's some, it's sort of like an easier buy. It's also quite cheap, relatively speaking, for the hundreds of thousands of dollars of coverage that is possible to get from it. So I wondered if we started stratifying it, like the difference between buying the garden variety healthcare policy and buying a fancy chunk policy if you owned fine art or a collectible or something. The blue diamond, whatever that thing was called, the Infanta Margarita's diamond that was in the New York Times recently. So if you push or pull out like toffee these different aspects of the plan and give different incentives to people to have certain levels of coverage and perhaps push that piece off and allow the federal government to offer just that. And maybe it operates like a gap policy, who knows? I'm not expert enough in these issues to sort of figure out how you could do that. But the idea possibly of separating wellness coverage from the regular home insurance policy from the CHUP policy, the fancy one, or something else, might then open up more ideas to come to the floor. Because right now what we have is one side puts up an idea, the other side immediately demolishes it without really ever offering anything that advances the conversation. It's just, you saw that cartoon in the New York Times. One side says no, and then they change sides, and the other side says no. There's never anything happening in the space. What do you think about the idea of the flood insurance style?
Well, I won't respond specifically to that because I haven't thought about that, but there seems to be no shortage of ideas in the healthcare reform debate. There are ideas all over the place. It's just that every idea, as you indicated, is immediately politicized and becomes a political punching bag. And so, and I think this may be what he didn't specify healthcare reform, but I think the sentiments that Evan Bayh expressed yesterday are exact. You can't even have a conversation about an idea that may go against what is thought of as the litmus test for that particular approach. So, if you're not for this, you're against everything. I mean, and it's become a situation where it's unhealthy with regards to, it's not just healthcare reform with regards to that issue. And I don't think that's a function of our system, as I think more as a function of how our politics has evolved or devolved into this very bitter quasi-ideological battle where there is no middle ground for taking these very different competing ideas, working them through the political process and coming out with pragmatic policy at the other end. We aren't seeing that, and it's not just on the healthcare reform debate. Unfortunately, with the midterm elections looming, it's hard to see an incremental idea gathering, because it's not big enough to matter for the voters' purposes, so why would you spend political capital on, I mean, it's difficult to see your idea of this other type of approach gaining any foothold with regards to where the politics is today.
I'm not sure I'd use flood insurance as an example because, of course, it's cheap because the federal government subsidizes it. And what it does is it encourages people to build in floodplains. So you have people who build in areas they should not build in. I mean, it's almost the most utterly perverse insurance you can have. You know, the barrier islands of North Carolina probably shouldn't be built on. People build on it because they know that we will help pay them if, the usual hurricane shows up and destroys their house. I mean, there's a larger point you make, but flood insurance doesn't strike me as the best example. But I was going to get to that. I think the idea of catastrophic coverage is a very important one, but that's the least problem that we have. I mean, that's the least expensive. It doesn't have all the add-ons. I mean, catastrophic coverage is really insurance as opposed to prepayment of expected medical expenses. The best way to get expanded and lower cost catastrophic care, I would say two things. One of which, basically the basic is you nationalize the market. You eliminate state regulations that mandate you have hair transplants and all sorts of other stuff, and you allow interstate commerce of insurance companies. So have genuine competition. I mean, there are hundreds of companies out there. Let them all compete if they think they can compete. Those, I think, would deal. We're still going to have the problem of people who can't afford it, people who have chronic conditions. I mean, there are going to be aspects potentially as problems of that we'll have to subsidize. But I think opening up the market, that's one of the easiest ways to get better and lower cost. Yeah, that'd be fine. Maybe, sure. I don't see any reason for antitrust exemption.
We're running low, so just the two people have already indicated, the gentleman there and Trent over there. Thank you.
Hi, I read a study about 2 years ago that said that 25 to 30% of us are born with structures in the brain that make us more likely to be conservative, and 25% are born that make us more likely to be, we could say, liberal. And it appears that way around the world, that these are fundamental, around the world. After looking at healthcare around the world, different systems, not as educated as I want to be, but at least for some of the big systems that do really well, they all have complaints about their system. Their people may live longer, they may have better health outcomes, they may cover, obviously they cover everybody. There's not 45,000 people dying per year in America, supposedly from lack of insurance. But they all have worries about their system, whether it's run by a nonprofit, run by government run, or here, we're the only ones who have the for-profit running it, or deciding do you care, do you not get care. What if we had a system, maybe around the world even, that had all the benefits of all three systems, nonprofit run, government run, and for-profit? Let people choose to choose a for-profit company. Let them choose nonprofit. If 30% of people are conservative and they understand for-profit, they understand it, they actually run it well when they're heading this. They really know what they're doing. Same thing with liberal. They believe in government run. They're actually, they understand it and they like to run government run. What if you allow people to choose where they have their health insurance so that we probably see the mix that we have in real life, which is 30% of people would choose for-profit, 30% of people would choose government run, 40% of people might choose nonprofit. I mean, I'm considering them independents. And then we would have the benefit of the for-profits, where when you have a mix of for-profits, more than one company, the number of companies, you actually get a slightly to moderately higher level of innovation with that than you have with the nonprofit or government run. Government run works really well in a way that they can top down just say, okay, we're implementing this with all the people. So the for-profits would have a slightly higher innovation. The government run would take those innovations, or in the whole systems, but definitely from the for-profits, would implement them top down on the rest of the people, have everybody run through that. And then the nonprofits who have more of the long old systems are, they could go and implement it piecemeal by what effects they saw with people that were implemented. I do understand. I don't know if you understand that part of what I'm saying, but I believe that we have the innovation of the for-profit, the implementation speed of the government run, along with the long-term wisdom and more nuanced of the non-ideological nonprofit.
Of all the systems I've seen around the world, it seems to me that the president's proposal comes closest to the one that you have just outlined.
Yeah, the original proposal before the public option was removed. I would agree. Yeah.
I think the problem is they don't operate independently. So if I create a government insurance plan, who pays for it? I mean, so if I want a private insurance, do I have to pay taxes to subsidize? You know, is it a system that operates theoretically autonomously and pays for itself, or is it a system that's subsidized? I mean, we have a problem of cost shifting from the uninsured. We also have a problem of cost shifting from Medicare and Medicaid. If you accept those payment systems, you don't get paid the same reimbursement rates. You know, it goes into your rate base just as if you take somebody who's uninsured and doesn't pay. So I don't think you can kind of separate them neatly, where I say, okay, you can have your public plan, don't bother me, I don't want to pay taxes for it. Well, then how is it a government plan? I mean, if it's going to be a government program, especially if it's going to take a disproportionate number of people who have lower income, it's going to have to, so I don't see how you can neatly separate them.
Now, I'm not sure the gentleman up the back was neatly separating them, Doug, that he was perhaps envisaging a world or a system in which there is a slight bit of subsidy from one group to the other, but that's the price.
Well, we have that to some degree today. We have Medicare and
indeed.
Medicaid, we have high-risk pools, we have public health.
We
so we have a lot of governmental systems within. We have a lot of non-profit health insurers. We have private operators. So we have a very but part of the inefficiency of our system is this mix where they don't quite interrelate very well together, and some of the incentives created utterly unintended. But the incentives have actually created a much higher cost system, you know, being in this middle with all this stuff, as opposed to trying to be more one side or the other.
Do you remember in 1980, before it was actually taken away, we had one state-run you could call it nonprofit, one state, controlled nonprofit in every state. So you could choose a private company, you could choose a nonprofit company within your state, or you could, you might fall back on the Medicaid or Medicare, which isn't really choice, but it also, it does take a large number of people. But I believe that's when we all thought we had the best health care. We actually had a mix of the three systems, even though the third one wasn't the government run wasn't choice. But we had a for-profit system, nonprofit if you chose to move to the nonprofit. We lost that when we allowed all the nonprofit, or almost all the nonprofits, almost all the states, allowed their nonprofits to switch to for-profit. Like here, Anthem clearly used to be nonprofit, and now they've taken over the private health for Indiana, and now they're like 70 or 75% of the private health care, which is, they're once again a monopoly, but now they're, they're near monopoly, but now they're a for-profit, and all of our, but you understand, back then we had that mix.
I think less important than the character of the operators is whether or not you have competition across state borders. I mean, as long as we have 51 markets, we've balkanized the system, so it's much easier to try to monopolize or near monopolize one state than it is to do the nation. Have a fully competitive system. We're more likely to get around that and have more, better choice.
Trent.
I want to state first of all that I may be making an assumption about where money goes between the state and federal government. I want to go back to Professor Fiddler's assertion that we can't increase care without costing, basically, having a higher net cost. I see two really large inefficiencies in the system. The first is where I may be making an assumption about it, and one of the only rational things that I've seen, and there's some significant ones out of the Republican side, is the idea that we already have universal health care, in the sense that if I show up in the emergency room bleeding or low pulse, I'm going to get care under this state law almost every state. Yet we don't provide the type of maintenance care that can prevent these emergencies. Isn't that a serious inefficiency, and can't we really save some money by providing the type of maintenance care that, it doesn't make sense to blow up a motor to change the oil. The second aspect of where inefficiencies are is since 2000, I've read estimates between 400 and 700% is the increase in the top 10 HMOs profits. despite any idea there might be something immoral about making profit off healthcare, isn't there a way we can kind of do that and increase the care we're giving people? I mean, isn't there something really holding our whole nation back if we're spending so much money just keeping the team running? I mean, we don't see professional basketball teams spending 7, 9, 10, 14% of their expense on the team doctor.
In terms of, to answer your second question first, and I think this is part of the problem with this, the approach that says that the 75% of the American population that gets its insurance through employers, if you're happy, we're not going to touch that. That's a problem, right? There isn't real competition in the biggest chunk of this. So there's no wonder the insurance companies record record profits, because it's been explained why nobody cares about who pays for this and the costs of this. We tend to worry about sort of the ones that fall off the coverage, but a huge part of this problem has to be those inefficiencies. And there are ideas out there, you heard some of them here, in terms of, well, let's make it a real national market so insurance companies have to compete with each other, so that I or others actually have to take some responsibility for the amount of money I think should be spent on my health care. At the moment, I don't know when it happens, right? I mean, this is part of the craziness of the way in which 75% of the system works today, and the reform has to address that. And this is what bothers me with what the president says, right? If you're happy with what you got, we're not going to touch it, you're not going to have any effect of that. It just isn't, first of all, it's not good policy, second, it's not believable. In terms of the flip side issue, in terms of inefficiencies and some of the problems that can be dealt with there, I don't think you have any disagreement with regards that improvements can be made with regards to that. I think the differences come in how do you go about doing that. And we can go back to the old platitude of, we're just going to squeeze the savings out of wasteful government spending, which is essentially what the president has argued with. They're going to find all of this money to pay for everything else through squeezing waste and inefficiencies out of Medicare and Medicaid. Well, we haven't seen that happen before, so it's a very difficult plan to believe in terms of dealing with the inefficiencies that we all agree are there. It just isn't plausible. It's not a credible argument.
I mean, there are a lot of things that may offend our moral judgment. It's not clear that they matter a lot in terms of cost. We spend almost $3 trillion on health care. The profits of these companies is just not very much compared to that. The insurance companies made 3% last year. It goes up and down. I mean, the point is, if you're looking at raw numbers, it's just not very much. And I mean, the amount of fraud and waste in Medicare is thought to be tens of billions of dollars. The challenge on this, of course, is that there's no line item that allows you to just pull it out. I mean, I worked for Ronald Reagan, date myself, but I was in the campaign, and he had a line of, we're going to get rid of waste, fraud, and abuse. It was a great line, but of course there is no line item in the budget that's waste, fraud, and abuse. And the difficulty, there's a lot of unnecessary care that's provided. The problem is, how do you get at it? And that's the real challenge for us. So if we can bring down profits, I'm happy to do that. I don't like high, salaries. I mean, all this stuff is fine, but it's not the essential. The problem is we have incentives that are built into the system. You can argue doctors make too much. I mean, I don't know what too much is, but there's an argument that specialists, Medicare probably underpays primary care and probably overpays specialists. Very hard to adjust it, though, because the moment you walk into Congress, everybody shows up and gets upset if you're trying to adjust their reimbursements. On the issue of preventive care, the challenge there, maintenance care, is you're right, but it's not always, it's easy to decide what's cost-effective and what isn't. And again, some of the best preventive care is going to cost you money. I mean, the problem with preventive care is you give it to everybody, even people who aren't sick, or you test everybody, even if they aren't sick. You get false positives, and you incur a certain expense treating people who, in fact, don't have the condition. And then you compare it to how much money you didn't spend. And I would argue in the case of mammograms that even if it is true that you save money by reducing the number of mammograms, there's a good argument to say we should spend it anyway, because that's a very good healthcare investment for the women involved. That in fact that's the kind of thing we would want to spend money on, because we catch breast cancer earlier, we can treat it, we save lives, so even if on some net social basis it costs money, we should spend it. So you're right, one of the problems of Medicaid is we underpay, so doctors are less likely to take it as primary care, which means you show up at the emergency room. It costs more, it's inefficient, it overloads the system, it has all sorts of perverse effects, which there I'd say we need to pay more for Medicaid. I mean, that's just one of those things, again, you want to help poor people, it will cost you. Let's bite the bullet. We have to do that.
I would like to go on much longer on these very, very interesting and important issues, but our organisers are indicating we need to wind it up, so I'd just like to thank our panel of very distinguished speakers.